All right, welcome back. Today we are diving into something you're going to see more and more in the clinic, the incidental pancreatic cyst. Honestly, with the kind of imaging we have now, these are popping up everywhere. So if you're a trainee on surgery or GI, you need to know this stuff. Let's get you up to speed.
Okay, let's kick things off with a number that might actually shock you. Somewhere between 40 to 50%. Yeah, you heard that right. Of patients who get an abdominal MRI for some completely different reason end up having a pancreatic cyst. That is a massive number, and it's exactly why this isn't some niche topic anymore. It's core knowledge.
And you know, as soon as you see one on a scan, it forces this one huge question. Is this thing just a harmless little blob, a benign bystander we can tell the patient not to worry about? Or is it a precancerous lesion, basically a ticking time bomb that we need to deal with? Answering that question? That is the entire game. So how do we even start to figure that out? Well, the very first step is always the same. We have to classify it. Think of it like a sorting hat for cysts. Every single pancreatic cyst gets sorted into one of three major categories, and that first sort tells us exactly what to do next.
So here are our three main buckets. First up, you've got your inflammatory fluid collections. These are almost always the aftermath of pancreatitis. Second, there's a small group of pretty rare non-neoplastic cysts. And then there's the third one, the one we really care about, pancreatic cystic neoplasms, or PCNs. This is the group that can turn into cancer.
Let's just quickly talk about the most common inflammatory one you'll see, the pseudocyst. The key is right there in the name. It's pseudo. It's a false cyst. It's just a walled-off pocket of fluid that forms after pancreatitis. And the most important thing to remember is it has no true cell lining, no epithelium. Okay, so this distinction right here is everything. It's the first, most important fork in the road. As you can see, inflammatory things like pseudocysts, we only treat them if they're causing problems, if they're symptomatic. But neoplastic cysts, those have to be taken seriously from the get-go and worked up for their cancer risk. Get this distinction down, and you're already halfway there.
All right, so we've set aside the inflammatory cysts. Now let's focus on the main event, the pancreatic cystic neoplasms. Look, for any trainee, there are really four big ones that you just have to know inside and out. These are the main players.
Now check this out. This chart shows you the breakdown of cysts that actually end up getting surgery. And wow, look at that. Almost half of them are IPMNs. So right off the bat, this tells you where to focus your study time. IPMN is king, followed by MCN, the serous cystadenoma, and then the much rarer SPN. Let's meet them one by one.
First up, the serous cystadenoma, or SCA. I want you to think of this as the grandmother cyst. You typically find it in women over 60. On a scan, it has this classic microcystic kind of honeycomb appearance. But here's the real punchline. Its potential to become cancer is practically zero. It's exceedingly rare. This is the one we are always happy to find.
Next, we have the mucinous cystic neoplasm, or MCN. Think of this one as the mother cyst. It's almost always in women, usually over 40, and it loves to hang out in the body or tail of the pancreas. For your exams, you have to burn this phrase into your memory, ovarian-like stroma. It's the dead giveaway for an MCN. And unlike the SCA, these have real malignant potential. The recommendation is pretty much always resection.
And here is the big one, IPMN. It's the most common one we see, and it affects men and women pretty equally, usually over 50. Now, the single most important defining feature is that it communicates with the pancreatic duct. That is absolutely critical, because its cancer risk depends entirely on which duct is connected to. If it involves the main pancreatic duct, the risk is high. If it's just in a little side branch, the risk is way, way lower.
And finally, we have the SPN. We call this one the daughter cyst. It's rare, but you have to know it because the demographic is so specific. Young women, usually under 35. On imaging, it looks like a mix of solid and cystic parts. And just like the MCN, it has significant malignant potential, so the standard of care is surgery.
Okay, so we've met the key players. Now for the practical part. How do we figure out which one we're actually dealing with when we see it on a scan? Let's walk through the diagnostic toolkit. This is your game plan.
The approach here is really logical. Step 1, you start with really good imaging. MRI with MRCP is the gold standard because it gives you the best pictures to see the cyst's features. Step 2, you put on your detective hat and you hunt for worrisome features. Is it big, say over 3 centimeters? Do you see a solid chunk in it? Is the main pancreatic duct getting stretched out? If you see any of that, or if you're just not sure, you go to step 3, you bring in the advanced tools, like an endoscopic ultrasound, to get up close and maybe even stick a needle in it to get some fluid.
So, after all that workup, all the imaging, all the analysis, this whole journey funnels every single patient, every single cyst, down to one fundamental bottom-line decision. It's the only question that really matters in the end.
Do we watch it or do we resect it? And this slide just lays it all out perfectly. In the surveillance column, you've got your definitely benign serous cystadenomas and those low-risk branch duct IPMNs that don't have any scary features. In the resection column, it's basically everyone else. All MCNs, all SPNs, all main duct IPMNs, and any cyst of any type that starts looking weird or causing symptoms. This right here, this is your cheat sheet.
So there you have it, a high-speed tour of the pancreatic cyst. We'll end with a final question, one that really looks to the future. Our imaging technology is just getting better and better, which means we're finding tinier and more numerous cysts than ever before. So the challenge for your generation of doctors is going to be this. How do we get even better at telling the dangerous ones from the harmless ones so we can perfectly balance the risk of cancer against the very real risks of a massive operation like pancreatic surgery? It's a huge challenge and something to keep in mind on the wards. Thanks for tuning in to this explainer.